Right on, here we go. And hello and welcome to everyone out there in internet land. We're back once again with a Pearls of Wisdom vlog. This time I'm joined once again by my brother in eyebrows, Dr. Jim Elliott from Northwestern University. Listen, man, you have to admit we both have pretty powerful eyebrows.
Yeah, I've never heard that before, actually, Dave. No one's ever told me that.
No, listen, man, these are fantastic. Do you ever get yours groomed?
No.
I've been told that's a thing, and I have had to go to the barber, and they've actually trimmed my eyebrows.
Without even asking you, I'd imagine, too.
What's that?
Without even asking.
No, because they get a bit out of control. It won't be long before it's my ear hair and nose hair and all that sort of thing. I wish I could grow it on the top of my head, though. But anyway, that's a different story. So, geez, Jim, thanks for joining me here today. We've got a fun little topic to talk about, and I know this is something that both you and I feel somewhat strongly about. And I'm just going to introduce it. We're going to sort of use a paper as a jumping off point, and the paper is called "The Development of Medical Imaging Technologies is the Best Way to Advance Clinical Diagnostic Accuracy, and there is no such thing as vomit." This is by McCubry and Reed, and it's a 2012 paper from the Journal of the Royal College of Physicians, Edinburgh. I'm going to put a link to this in the comments section below. It's not an open access paper, so only those with library access or with access to that journal will be able to get this paper. But it's a great jumping off point. I wouldn't be at all surprised if some of the people who are watching this video have heard of the VOMIT acronym in the past. It stands for Victims of Medical Imaging Technology. I certainly know there are clinicians and professional development providers out there who have sort of hung on this acronym and in sort of a bit of a facetious way, I suppose, possibly trying to make a point. You have forgotten more about imaging than I currently know. And
no, never mind, David. That's quite all right. And I think it's important to say there that while I may know a little bit about imaging, that's certainly because of some efforts on my own behalf, but also I've had the good fortune, as you know, to work in an interdisciplinary fashion with people that know a lot more about imaging than me, and that's actually shaped my entire academic career for sure.
Yeah, no, absolutely. And I mean, listen, that's why I think I like working with you, because the imaging field is not something that I'm overly familiar with. I am becoming more familiar, thanks in large part to my collaboration with you. So why don't we jump into this? I think it's kind of a comical, it's a quick little paper, it's really an opinion piece. And I think maybe the first thing that's worth mentioning is that McCubry and Reed discuss a couple of other acronyms that are out there as well. I see BARF, I see Ordure, I see camera. Why don't you talk a little bit about those as well, Jim?
Yeah, sure, man. I think you're right. It's a great paper, and it provides a nice foundation. I quote from the paper: "The increasing accuracy brought by advances in imaging technology brings an inevitable flurry of incidental findings." I think we can all chew on that and agree with that, because geez, MRI in particular is, as I've said before many times, it's the crowning achievement of human ingenuity. I can't tell you the number of Nobel Prizes it's been associated with. I think it's very safe for me to take a strong position and say MRI is not the problem. We all know that it's a very sensitive modality. It can identify pathology in an asymptomatic population. Nobody's going to disagree with that, nor will I. And I don't think this is our position to say MRI should be performed on everybody. Of course, we don't agree with that. But as you bring up these facetious acronyms, as McCubry and Reed state, BARF, the brainless application of radiological findings; Ordure, the ominous referrals for dubious, unattested radiographic examinations, leading to the suggestions for the setting up of the campaign for real ailments; or camera. And I think it's important for us to provide the backstory here, is that VOMIT was first introduced in a personal opinion paper in BMJ in 2003 by Richard Hayward, a pediatric neurosurgeon, who presented some hypothetical examples of innocent pathology found on MRI, and that no doubt created considerable worry for the individual and their families. That anxiety was probably fueled by a very fervent internet search of what does this mean, a lot of potentially misinformed opinions about what it is. So we also know that in our own field in physiotherapy, this term has been thrown around quite a bit on the internet, and there's probably a lot of people that sort of buy into this, that there's victims of medical imaging technology. And that really chaps my hide a little bit, because we're a primary scope profession. We can and probably will be involved in the ordering of imaging. And as I hear people, luminaries in our field like Bill Boysenalt, who I have a ton of respect for, and he says, it's important for us to realize the language of imaging and referring for imaging, but do we want to be a profession that's just part of the problem? And when he refers to that as part of the problem of just unwarranted referrals for imaging as a first line pass, you know what? We don't want to be part of that. We're, I think, good enough in our musculoskeletal exams, in our assessments, to understand and utilize existing guidelines when they exist, because they do exist, of when imaging would be appropriate. That's the bottom line.
Yeah.
I also, Dave, I get a little out of control with this sometimes, but I also think in a very lucid fashion, it's important to mention some of the emerging work. If we just think about, say, Mark Hancock's work in Sydney, he's done some really nice work to say, let's take a step back and think about these pathological findings. And we should also provide a link to Mark's paper in 2014, 15, in the Spine Journal, Risk Factors for a Recurrence of Low Back Pain. And, actually looking at your risk for recurrence of back pain based on the number of pathological findings read out at baseline. I won't go into great detail on that paper, but I think providing a link to it would be appropriate.
Yeah,
and I think it's important for us to remember that, utilizing this modality in a judicious way is actually a very potentially efficacious way to assess and treat our patients.
Yeah, geez, Jim, it's interesting. You made the comment earlier, and I fully agree with this, that it's not the imaging technology itself that's the issue, but perhaps there is a legitimate argument to be made that we need more informed referral patterns or more informed requests, we'll call them, for imaging. And certainly without trying to derail this conversation and move it on to something else that, as you know, I'm deeply passionate about, but it strikes similar feelings to me as the opioid conversation right now, which is maybe that opioids are not the issue, but it's the prescribing patterns. It's that we need more informed prescribing practice. We need more informed patients. And I think the same thing could be said for imaging, that, there is certainly a place for it. In fact, I'm looking at the McCubry paper right now, who quite rightly states that a lot of these are more sensitive than they are specific. And perhaps that's maybe what some of these people who are trying to endorse these sort of, facetious little VOMIT acronyms that are in a somewhat more clumsy way are trying to say, perhaps, is that you're going to see a lot of things potentially on imaging, and they may or may not actually have anything to do with the patient's clinical presentation. But, and I think this is where sometimes people are trying to sort of make a point fail a little bit. When you do see something on imaging, those are potentially very important. So while there may be a large group of people for whom there's nothing of substance is going to show up, something may show up. And when it does, you don't maybe want to ignore it. I'm just looking as I go further down this paper that incidental isn't always trivial. So there are going to be sometimes things that show up there. So yeah, anyway, I think it's, I can appreciate the argument that it's a more sensitive modality than it is specific, but that still has its place. There are lots of things we do in physio practice that are more sensitive than they are specific. And people will be familiar with the spin and snout rules, for example, talking about acronyms that are a negative result on a highly sensitive test might be useful for ruling something out. Well, isn't that still of some value for some people?
Yeah, absolutely. And it's important to mention, I think it's related to some of the emerging collaboratives around North America and certainly the world. As you know, we've got an emerging imaging collaborative going on, and this is more for our entry-level students. So in teaching our entry-level students about imaging, purely my sense is interpreting pathology is at the level of the radiologist, full stop. Story ends right then and there. For us, though, we may be involved in referring for imaging. So we, from day one in our entry-level program, and this collaborative is actually quite nice because it's trying to ensure that all of our entry-level students get kind of the same message, and that is utilize the guidelines, use those to your advantage to make good decisions. And as you well know, Dave, better than most, if not all, guidelines are guidelines. They're not law, but they do help reduce the variability in clinical practice. I think this has been great because by the end of our students' sort of tenure at the university, geez, they know those guidelines and they know them in and out. So if they're involved in clinical practice, which they will be, they can make a more informed decision. I think it's clear. We do educate them that, you may find some things on imaging that don't relate to the clinical signs and symptoms, and therefore, great, we're not going to sort of treat the image, we treat the patient. We know that. But I'm very impressed by what I'm hearing from our entry-level students and their decisions to make a referral back to the physician that is supported by evidence, it's supported with good language and repartee between the referring physician and the physio, which is great. I think that can only help us. And I think it better ensures that we're not just going to be part of the problem. And the problem I see it is that totally ridiculous referrals for imaging as a first pass musculoskeletal exam. Geez, you've got low back pain, let's get a scan. Well, of course we don't want to do that. We don't want to be a part of that. But let's not throw imaging under the bus with silly acronyms such as VOMIT.
Right. Yeah, no, I fully agree. And I think unfortunately what that ends up doing, when you think about it, don't let your patients become vomit. I can't think of a better way to interfere with that sort of patient-provider interaction or that therapeutic alliance that you might have by saying to your patient, I don't want you to become vomit. Regardless of how well-intentioned perhaps the comment may be, boy, that's just kind of rude and disrespectful to me. Maybe I'm thinking too much into it. This conversation reminds me of a paper that actually, it's one of my favorite papers, in fact, and I quite like qualitative research. It's a lot of fun to read. And there's a 1999 paper that Rhodes was the primary author. It's called The Power of the Visible and the Meaning of Diagnostic Tests in Chronic Back Pain. And boy, it's fascinating to think about, chronic pain and what role diagnostic tests may play in that. Chronic pain is one of those few conditions, very few that I can think of, where people are disappointed in a negative finding and are hoping for something to show up. You think about most other disease states, people are hoping for a negative finding, that it doesn't show something. And yet in chronic pain, I think because we live in this world where if you can't see it, it doesn't exist, that seems to be the sort of going cultural belief that our patients are actually hoping for something to show up on their imaging, I think, so that they can validate or legitimize their complaints. What do you think about that, Jim? Do you think there's something to that?
Yeah, I do, Dave. I think, as you know, that there's like this plethora of interdisciplinary work that is being accumulated around the world today, and it's easily accessible as well, as you know, and it's helping us understand and unlock some of the mysteries of chronic pain, and it will continue to do so, in my opinion. And I dare I say it will continue to do so if we follow the advice of potentially the greatest scientist of the 20th century, Albert Einstein. And what did Albert Einstein say? He said, we can't solve problems by using the same kind of thinking we used when we created them. And I'm ending that on that note, but to me, it rings true. And, neither of us have been hurt by knocking on the doors of other disciplines when we don't know the answers. And believe me, there's plenty of answers or questions I don't know the answers to. So we're very fortunate, aren't we, to have colleagues in other disciplines, whether it's medicine, chiropractic, psychology, neuroscience, MR physics, the list goes on. Working in those circles has certainly opened my eyes to different ways of looking at these technologies.
Yeah. So maybe then, Jim, why don't we, as we wrap this up, can you tell me a little bit about, from Jim's perspective, the view from sort of in there, where are we heading with this? What's the next great frontier for imaging, or even just talk a little bit about what you guys are doing, in particularly imaging for musculoskeletal pain?
Yeah. So, having learned from others that I've worked with, I can certainly think of my time at University of Queensland with Gwen Jull and Graham Galloway and Michelle Sterling, and certainly working with you. I think it's safe to say we can assume that there's 3 different trajectories in musculoskeletal pain, very similar between low back pain and, say, traumatic neck pain. Sort of this, recovering group, this mild pain-related disability and severe pain-related disability. And as we all are starting to realize and putting our hand on our heart, it's a small percentage of people that fall into that severe category. And we can kind of tease them out with some good confidence around a month following the onset of pain. The things we're working on now is this whole idea. Now, certainly, I'm in a research environment where we do serial MRI on these folks. We're funded to do that. We're not advocating that everybody who has, say, a motor vehicle collision needs a scan, and they need scan of the brain, the spinal cord, the muscles. But what we're uncovering is that, we could probably, with the results of this, use good assessment tools to figure out risk for recovery or poor recovery. And I'm of the ilk now where if we just sort of hang on to that, get a good handle on where they might be going with a good assessment, imaging is, once they've been cleared medically, imaging is not needed in really the vast majority of these folks.
Right.
But in about 2 to 3 out of 10, it may be. And let's just wait a little while. Let's wait a month and let's see where they seem to be going. Granted, there's a lot more work to be done, but I'm becoming more and more convinced that some of the advanced imaging technologies, some of the work that I've read from Mark Hancock and his group in Sydney, there's probably a real need in a small percentage of these folks. And I think we, as physios who treat these people and assess these people, can make that judicious referral when the time comes.
No, exactly, and I think that's actually a perfect message. Is actually cycling back to what you had already started off this conversation with, and that is that it's not that imaging is the problem, but it might be the referral practices, and perhaps what we need as this technology continues to advance, and we know it is, and as you've quite rightly said, this is some of the most advanced technology that we currently have access to. But we need, as physios, even as physicians, as anyone who refers for this, better understanding of who to refer, when to refer them, why to refer them, specifically what we're looking for. I love what you're doing with the physio students there, getting them to speak the language of the radiology field so that they understand the difference between T1 and T2 weighted images and know the right sequences to ask in order to actually make informed comments and requests. And hopefully we get to the point where we do get away from perhaps unnecessary imaging. I'm fully on board with that concept. Let's not pay for unnecessary imaging. Let's not potentially cause fear in patients where it doesn't need to be. But on the other hand, let's not ignore the technology. Let's use it for what it's able to do. I think you've hit on something absolutely critical there. This I see as one of the future directions of physio practice, and good on you, man, for pushing this forward.
Well, thank you, Dave. With everyone's support, it's great. I'll end on this too. I just want to say, I think it's important for us and to maybe have a little bit of a call for action, get out of our comfort zone a little bit and attend other conferences.
Yeah.
Go to a radiology conference, go to a spine surgeon conference, go to a psychology conference, go to an emergency medicine conference. If you have some work you want to present, submit an abstract for it. We're, dare I say, a little bit parochial sometimes in our own little circles.
Right.
And nothing is better when you can go to another conference, engage in some conversation with other disciplines, learn and teach them as well. It's never hurt us, for sure.
No, absolutely right. Absolutely right. And I completely agree. The only way we're ever going to move forward is to push the boundaries and get outside of our own little silo of what physio has traditionally been. So on that note, thanks, Jim. Thanks for joining me.
Thank you.
Hopefully you can't hear the sirens racing by outside my window here.
I can hear them.
Yeah. No, this has been great, and we'll do this again sometime. So cheers.
Fantastic.
Have a good day.
You too, Pat.